Hello, everybody. This is the voice PowerPoint on validity. So we're going to talk a little bit about minimizing the threat to validity. So threats to validity, we want to keep in mind that there are goals of experimental research. And those goals are to think about things in a couple different ways. First, is there a relationship between the independent and dependent variables? And if there is a relationship, is there evidence that one causes the other? And if you have that cause-effect relationship, then what theoretical constructs can be the results? And can those results be generalized? So, so let's delve into this a little bit more. There are four types of design validity. You have statistical conclusion validity, you have internal validity, you have construct validity, and external validity. When we're talking about statistical conclusion validity, there are several factors that influences this. So the potential to draw conclusions from statistical procedures that would be inaccurate can come from analyzing the data and leading to invalid conclusions about the relationships between independent and dependent variables. And this happens if you have low statistical power. So if you haven't calculated the power or sample size before you start the study a priori, then you may have low power to detect differences, and the differences or lack of differences can be related to your sample size. So it's very important as you're critiquing these studies to look at the power. Another thing that can influence your findings are violated assumptions of the statistical tests. And the specific tests have different assumptions. Many times the assumptions have to do with a normal distribution of the data. So if you have a skewed distribution of the data, you can't use some statistical tests. So you want to pay close attention to have they acknowledged what the assumptions were and whether or not the assumptions were met. Another thing can be error rate, and it increases with repeated tests. So if you're reading a study and you see that they did multiple t-tests to look for differences between groups and they didn't really adjust the alpha for that, that really increases your error rate. So they should either be using a different statistical test or increasing the alpha, so that basically you need a smaller p-value to be significant. And then the reliability. So is this a really reliable instrument that we can say is precise in measuring the outcomes that we're interested in? And is there variance in this sample? And we kind of talked about that already with the normal distribution. And then failure to use the intention to treat analysis. So that means that if I randomly put people in a treatment and control group, and the people who are in the control group know that they're not getting the intervention, and they drop out, and I don't get the post measures on them, I am not using intention to treat analysis because those people are gone. So you want post measures on everyone, no matter what, so that you can analyze everybody's data. Internal validity, when we think about the internal validity, the assumption of causality requires three different components. First is the temporal precedence. So the thing that we think is the cause needs to come before the thing we think is effect. So there also needs to be some covariation of that cause and effect. So those variables need to go up and down with each other. And also, there's no plausible alternative explanations. And in reality, there's always other alternative explanations, and you try in your design to control for those. So here's an exhaustive list of all the threats to internal validity that you should be thinking about when you're critiquing these articles. They're listed for you there, and they're also discussed nicely in your textbook. So let's talk about a few of these individually. The threats to internal validity that I want to cover first are history. And history refers to events that occurred during the study which could influence the outcome. And when we were doing our obesity study, the 24 site school-based health centers being trained on the obesity guidelines, there was something coming out in the media every day about childhood obesity and the importance of identifying it and counseling it and different interventions. So the history, the events that occurred during the study could influence our outcome, but it should influence both the treatment and control the same. But that's the importance of having the control group then. Maturation is another thing that you have to take into consideration. So are the changes in the research subjects over time, like developmental changes or physiologic changes or the disease progression? So is what you're seeing a result of your intervention, or is it just maturation? And a good example from our childhood obesity work again is if you look at the chance of obesity in kids increases with age. So you could say that it's just the maturation that made the changes in the groups. And so you have to take that into consideration too. Mortality is another factor that can influence your findings, and that's research participants dropping out. And the intention to treat analysis controls for this threat, but you have to collect the data on the participants, the post data on the participants who drop out. So both the treatment and the control group participants who drop out need post-test, and sometimes that's a little tricky. The other thing you have to worry about is testing. Repeated testing can change the outcome independent of the intervention. So is it just the fact that you've done this test multiple times that they're getting better at it, not as a result of the intervention? And we did the cardiorespiratory fitness step test as an outcome, and as the kids are doing it, we did a repeated measures design, so 3 different times. Just the fact that they've done it before and they're more familiar with it could improve their performance on that test and have nothing to do with our intervention. Instrumentation is another thing that we worry about. And if a measure lacks reliability and validity, that is a real threat to your internal validity of your study. Some more things to consider is this tendency to regress toward the mean. So the outcome measures come closer to the population mean over time. And the control group helps, again, minimize this threat because it should happen equally in both groups. Selection bias is inconsistent selection of subjects, and randomization minimizes that threat. And then group contamination, the control groups gets a similar treatment or maybe a more powerful treatment. So those are other threats to validity. We also have to think about a compensatory intervention. So the control group gets an intervention to compensate for not being in the intervention group. And this happens in healthcare a lot. If the clinicians taking care of the patients are aware that they're the control group, they feel bad and they feel like they need to give them something extra to compensate for the fact that they're not in the intervention group. So we usually address this by having the double blind, both the clinicians and the people doing the outcome measures being blind to whether people are in the treatment or control. Now, that's not always possible either, but we do want to keep that in mind as well. And then compensatory rivalry is the control group subjects themselves know that they're in the control group, and so they adopt strategies to influence the outcomes for themselves. And in our childhood obesity work, this people knew if they were in the treatment or intervention, and they could say, fine, then we'll just do some intervention ourselves. And then there's resentful demoralization, which is kind of the opposite of that, where control group members are so demoralized by being in the control group that they just give up. And so their performance gets worse just because they're no longer trying at all. Then we want to worry about external validity, and that's the generalizability. So it's the extent to which the results can be applied to the broader population. And what usually happens early on in these experimental designs is that you have a very narrow population, and so it can't be generalized to a broader population. But the scientists need to provide a very good description of who their population was, and then you know that it can't be generalized beyond that. And if you're applying it to a different population, you may want to test it in that new population. So how are we going to minimize the threats to external validity? Well, you can start from the beginning by recruiting a diverse study sample. You can limit the number of exclusion criteria as appropriate, or plan for subgroup analysis, recruit from various practice settings, include a description of the practice setting to aid in generalizability, and describe the interventionists compared to the participants. And all of that increases the cost of studies and sometimes is not feasible, but it makes it more generalizable. And then you want to compare clinically relevant alternative interventions. So one of the things that can help avoid the compensatory and the competing rivalry is if you compare two interventions, then both the treatment and the control group are getting something. And so you don't have that concern that they're just trying to influence the outcome because they feel this person's in the control group. They know you're looking at two alternative interventions. You can also consider alternative experimental designs, such as a waitlist control. So you are randomly assigning people to treatment and control, but the control gets the intervention later. You can also measure a broad range of relevant patient-centered outcomes, things like quality of life, and this just helps with getting a clear picture of all the potential influences that the intervention could have on the outcomes. And then consider a longer length of follow-up to capture both the short-term and the long-term outcomes. And so the repeated measures design really helps with this. There's also a framework for assessing external validity that you may have heard of. It's called RE-AIM. It was actually first developed by Russ Glasgow, who was a professor at the University of Colorado in the Colorado School of Public Health. And he did a lot of work around cancer and cancer prevention. And so he worked at Kaiser Permanente in Colorado Springs initially, and really felt like the regular RCT wasn't a good way to address the work he was doing. So he came up with this RE-AIM framework. So the R stands for reach. How many of the population that you really want to have get like a screening for cancer actually receive the treatment. Effectiveness, or what are the outcomes? So that would be, are you picking up cancer earlier because you're reaching a big population and it really works to screen people. Adoption is uptake of the intervention, and that can be by both patients and providers. And colon cancer screening is an example of the adoption is just not that good because patients don't feel like that's a pleasant experience to get a colonoscopy. Implementation is, was it delivered as intended? What happens in clinical practice many times is you're short on time or you're short on personnel, and you kind of cut corners and you don't deliver the intervention as it was designed. And then maintenance is long-term behavioral change, and that's both at the individual and community level. And so once again, we may introduce something new and it's kind of exciting and everybody's following it, but as time goes on, it becomes tedious and time consuming and people get tired of it, and so they don't maintain that behavior, and the effect can drop off. So again, I'm going to refer you back to the CONCERT guidelines for reporting on an RCT, the checklist in Portney and Watkins, and there's a flow chart, and there's the link to the CONCERT statement. And these are the things that I want you to think about when it comes to reliability, or I'm sorry, validity, and the threats to validity and ways to control it.